board and get us started.
Okay, great. Thank you, Shanitra. Hey, everyone. Good morning. Welcome. So this year, we're excited to have guest speakers from other institutions. And today we have Dr. Ellington, talking about butchering names. We were joking about that earlier, from the University of Utah. And as we usually do, we'll hope to leave some time for questions after the presentation. So feel free to add questions in the chat or save some for the end of the presentation. And just as a quick intro to Dr. Ellington's lots of work, I'm going to introduce her. She's a professor at the College of Nursing at the University of Utah, a clinical psychologist, and a Huntsman Cancer Institute investigator. She holds the Robert S. and Beth M. Carter Endowed Chair. Her interdisciplinary program of research focuses on the impact of interpersonal health communication on adjustment, decision-making, and health. Dr. Ellington has 20 years of continuous funding from the NIH and the American Cancer Society, and for the last decade, her team has focused on research on hospice care of families facing life-limiting cancer. She's also the founder and director of the campus-wide Family Caregiving Collaborative, in which researchers, clinicians, health professionals, educators, and community partners come together to support the advancement of person and family-centered care, and where patients and caregivers define their family and determine how they will participate in care and decision-making. Collaboratives funded by NIA, foundation funds, and other philanthropy. Dr. Ellington co-directed the T32 Interdisciplinary Training Program in Cancer, Caregiving, and End-of-Life Care. She and her co-director are currently awaiting summary statements of another T32, which is new focus, while retaining emphasis on family caregivers. Good luck. She's mentored multiple trainees and junior faculty conducting research on families facing serious illness conditions, and in 2021 received the University of Utah Distinguished Mentor Award. Okay, so without any more, we'll go ahead and hand it over to Dr. Ellington. Thanks so much for coming.
Well, thank you for that introduction, and I'm very happy to be here, and I see some familiar faces. So I am going to do this amazing thing where I share my screen, and so I might try to keep up the chat. And so now, here we go, and I really will try to watch the time. That is in presenter mode. Okay, I'll just move you guys. I can't really move the chat, so I may have some chat stuff early on, but I may turn it off. So if there are questions, Danae, you can let me know.
Okay. Would you like me to just give a holler if I see something in a moment?
Sure,
in the chat. That's
great.
Okay.
Yeah. So I guess here's the title of my talk, and we'll just move right on. So usually acknowledgements are at the end, but I really wanted to take a moment to thank the hospice interdisciplinary team members and administrators that participated in this research, and also these individuals that provide care, this such important care in our community day in and day out. And the research team, the staff, and collaborators, our funding sources, and definitely family caregivers. And so for the purposes of this talk, we define family caregivers as chosen family. So a family caregiver can be a biological family, a friend, and someone who provides unpaid care to the care recipient. So just an overview of the talk today. I'll provide a rationale for a program of research in hospice communication with family caregivers, a very brief background to this audience on hospice, and then I'll discuss 3 projects to enhance that we've conducted to enhance the understanding of communication with family caregivers in hospice. So the 3 projects have a little different lens. The first one is a really foundational and big picture one that looks at prospective longitudinal communication. The second one is looking at a specific interactional domain, and that we're going to focus on positive emotion communication. It's one of my favorite little projects that we've done. And then finally, it's important to study the needs of specific populations and their communication needs, and we'll be looking at LGBTQ+ hospice family caregivers. And if time permits, I'd like to tell you more about what we're doing now with the Family Caregiving Collaborative, building infrastructure for impact. Okay, so persons with a serious illness and their family caregivers suffer physically and psychologically, and we all know many factors contribute to that, but healthcare communication and the beliefs and attitudes individuals bring to their illness and to their care encounters certainly play an important part. And we know that outcomes worsen when patients and families don't understand their illness, their prognosis, or their treatment options. And while there's been tremendous research on exploring the effects of health communication, much done right here at University of Washington, the work is far from done, and nowhere is that more apparent than in hospice care. So on the left side of this slide, I cite some research from Alexi Wright on the suboptimal communication in oncology clinical settings, and it's associated with effects at end of life. It affects the aggressive care near death, shorter hospice lengths of stay, lower quality of life at end of life, and worse caregiver outcomes during bereavement. So, but let's turn to the context of research I'll be presenting today, in which we study the triad in hospice. So we'll talk about the person or patient with a serious illness who gradually relinquishes their autonomy as death approaches, the family caregiver who provides increasingly complex care while managing their own stress and impending loss, and the hospice nurse who oversees and coordinates patient and caregiver interdisciplinary care. And in an institutional setting where clinicians provide the round-the-clock care, in the home setting, this requires nurses and other families on the care team, others on the care team to teach and support the family caregivers who provide the majority of care. So in our work, our primary interest is about meeting the needs of family caregivers who are in the home, and a lot of our work is based in cancer hospice care. So I'd like first to take a moment and ask each of you to think about where you live, your house, your home, your apartment. Some of you are there right now. And if you could write a word or phrase in the chat that comes to mind when you think of where you live. So what that space means to you. So I see a place of safe, a place of comfort, a place of peace, comfort and support, comfort. So really sort of getting this warm, comforting, safe space, a feeling of belonging. So, well, thank you for all those comments and where my family is. So this is, you know, the sense of a home. So think about, now that you've brought this to mind, if every day a stranger or a group of strangers are coming into your home, and some of you may have been involved in hospice care, but imagine sometimes you might know they are coming, or sometimes you might have a short notice, or maybe you're planning for them to come at a certain time and at the last minute gets changed. And think of these strangers bringing in new furniture, perhaps a bed, or pulling in equipment and rearranging your living space, opening your refrigerator, and all of these individuals that are coming in, you are quite dependent on. So while hospice allows people to die in their home, it's also a relentless invasion of an interdisciplinary care team coming and going in a place which many of you described as a safe place. So home-based care places some different demands and priorities on communications as opposed to communicating with families in bricks and mortar spaces. So now I'm going to shut off the chat because it was right in the middle of things. So just a little background on hospice care, particularly in cancer. We know that hospice is associated with positive outcomes. quality symptom management, reduced hospital-based services, and reduced medical costs for patients and insurance providers. You can see here the number of people that receive hospice care annually, with about 550,000 of those having cancer. And cancer is among the shortest lengths of stay in hospice, and it tends to have a more rapid and dynamic decline. So in hospice, families is considered the unit of care. And I was once at a conference and I heard a keynote speaker who was a palliative care researcher say, hospice has family-centered care all figured out. And this gave me pause, especially regarding family caregivers. And what does family-centered care look like for family caregivers in hospice, and particularly for families facing cancer? So this starts with our first project that I'll be discussing, which was really about some collecting foundational hospice communication research. This is a program project grant from NCI led by Kathy Mooney, and I led a particular project on this grant called Nurse Caregiver Communication and Implications for Caregiving and Bereavement. And just a little bit about this project. The study aims were just to generally describe hospice communication, to identify the overall trajectory of change in specific communication domains over the course of care, and see how communication predicted family caregiver bereavement adjustment. It was a multi-site study, and we followed patients or caregivers from hospice admission to 18 months post-patient death. And what's interesting about this study is we really struggled with how to capture conversations. And we really were fortunate that nurses were willing to wear audio recorders as they moved through the home, as they entered the home, and captured this communication. And we content coded that communication and conducted quantitative analysis. So this is a little bit about our sample. We ended up looking at 101 caregiver dyads. We looked at spouses, their partners, and most of the caregivers were females, as you would expect. We had 58 nurses. Their mean age was 42, and the majority were female. And the visited characteristics, we looked at about 5 visits over time per dyad, and then, or triad, we could say. And then the average length of a visit was around 40 minutes. There's a lot of conversation to look at there. And so some of you that may be familiar with the Rotor International Interaction Analysis System. It's a widely used and validated coding system, or RIAS sometimes called, which captures both the content and the process of communication. And it consists of mutually exclusive codes that are applied to every statement or phrase. And we combined codes to the Rotor codes to reflect 3 broad care domains. And the first was physical care. And so I'll walk us through this here. And as you can imagine, that in all cases, that involves giving information from both sides. And here we have an example of a caregiver saying, I gave 2 pills this morning. And then also in physical care, there's a lot of question asking. How long has he been having this pain? And we also looked at categories we called teach, activate, and partner. And this is nurse only. So if you think about a category such as activating or partner, someone might say we can work together to get his pain under control. So showing, really building a partnership with the caregiver. And another example is what I'll do next to check out. What I'll do next is check out that bandage, and that's an example of orienting the patient to what the nurse is doing. And then there's sort of checking back. Do these instructions make sense? Which is the nurse checking for understanding. And we coded these communication behaviors because a key goal of home hospice is for the care team to really assess and teach the family member to provide care. And we also had a domain that captured lifestyle and psychosocial communication. And this also consisted of information giving and question asking. So an example here is I've been working out in the yard most days, as a caregiver saying, and questions, and, how is your family coping? And a lot of the psychosocial codes did relate to family and friends. And finally, we looked at the emotion domain. And so we looked at distress or concern. I just can't stand to see my wife in pain. Is this how everyone feels? And then we looked at positive emotions. So there was a lot of humor. Of course, I love to talk about pooping, a nurse said. Lots of communication about pooping. And then a caregiver as a nurse is leaving their home saying, we love you. And then there were emotional responses such as, I know it's tough sometimes, or it's okay to feel that way. And the interesting thing about RIAS, you don't just using RIAS, you don't transcribe recorded visits, but you use the software where you digitally stamp every statement. And this is really valuable to capture the emotional valence of statements and better contextualize meaning. So let me just get to our descriptive findings, and I'll walk you through these three pie charts. So really, we're just describing on average the across all visits, the communication. And we see here that nurses spoke about the bottom pie chart, about 54% of all the total talk, with caregivers at around 30% and patients at 17%. And the largest shaded areas of each pie chart reflect communication in the physical care category. And that's as expected. And mostly these statements related to physical care information about symptom management. And the nurses very infrequently, or the caregivers very infrequently, talked about their own care and their own physical health. The next largest proportion of talk was lifestyle and psychosocial domain. And obviously, there's much more of this type of talk than you would see in an outpatient or inpatient oncology encounters. So this includes what's sometimes labeled as social chit chat, which in a clinical setting is considered moderately important for relationship building, or kind of a relational check-in, but we don't dwell there typically to save time, right? Whereas in the home setting, this talk pertains to activities of daily living. And, nurses are moving in throughout the entire home, often walking with the caregiver to where the patient is. So they would talk about gardening, food came up a lot, and recipes, and family memories and holidays. And this domain also included a lot of information about family and support. So this is really, the home really provides this unique canvas of clues about a family. And then we found about 6% of all nurse talk, the white segment, was focused on teaching and activating and partnering. Those categories we went into a little detail about. And this varied. We had some prior work funded by ACS that was qualitative. We tended to find that this was toward, it confirmed what we'd found earlier, that it's really toward guiding caregivers through experiences as if they were spectators. And there was less about really partnering with them and doing activities with them. And then about 10% of all talk was related to emotion. And there was about an equal amount of negative emotion, anxiety, and sadness to positive emotion talk. And we'll talk about this a little bit more later. So our second aim, we had predicted, and we had these fancy predictions, I'll tell you, about the relative level of talk devoted to the three care domains. And we thought these would change over time, really kind of maybe a snapshot into how relationships develop over time, and that physical care would be predominant, but that we'd see an uptick in emotional and lifestyle psychosocial talk over time. And while we found a slight decrease in emotional talk counter to a hypothesis, we're not confident that it represents a clinical meaningful finding. And what we interpret as more compelling is just really this high variability in the communication domains over time. And this is unexplained by nurse, by time of the course of the care, or diet effects, and rather it's just high variability likely suggests it's end of life, it's events-based patterns, really maybe the demand of the symptoms that the patient's facing and the caregiver's response. And finally, with all our fancy predictions, or hypotheses, we did not predict caregiver bereavement outcomes. But in conclusion of this first project, while we didn't support our hypothesis, this work was foundational in really having a large data set to really look at home hospice with the triad. And we really attempted to capture communication over time. And those of you that work in the communication arena, you know that this isn't often done. And we really need more sophisticated and targeted methods to figure out how to do this better. We found that the focus on, oh, I guess I'm really not talking to this slide, am I? Well, anyway, so the focus was primarily on symptom management, little caregiver self-care and coping. It's unclear if caregivers' needs were met, and extensive variability in hospice. And really, we see a need for more training in communicating effectively with family caregivers. So there are some novel contributions of this project. We really described communication at the end of life in an area that really hadn't been well studied before. And we tried to capture communication patterns over time, but this is really balanced in part by the limits of RIAS. RIAS provides an opportunity to code a large amount of data comprehensively, but it's really rather primitive categories. And so it just really provides us this big picture of communication. And also, this is manual coding that we did. We all know that's very time and cost intensive, and really excited about some of the new innovations with AI and natural language processing that may hold promise for advancing communication research. Okay, so now I'm going to our Project One data set provided this incredible opportunities for mentees and national collaborations in which we did a series of secondary data and analyses projects, asking different questions of our data and focused on the specific domains. And here's just some examples. We had a mentee that looked at caregiver activation. We worked with George Damaris on pain management communication, and Deborah Parker Oliver at University of Missouri on shared decision-making in home hospice, and Jennifer Chia on, that was a fun project, really looking at how do we talk about managing medications in home hospice. And so it was really fun doing these different projects, but I'm going to focus on one specific domain of communication, and that's positive emotion. And so this is a secondary data analysis from the data from Project One. So just a little background, I find this really interesting. I want to provide some background on positive emotion and health, and why we thought it was important to focus on this in hospice communication. So I'm going to spend a little time on the broaden and build theory of positive emotions. It's widely known and researched, and it posits that positive emotions broaden our awareness, they expand our repertoire of experiences, and really help us to build physical, intellectual, and social resources in the short term. And positive emotions can counteract negative emotions, and they really enhance stress recovery. And when shared, they really can create mutual enjoyment and social bonds. So think about the feeling you have when you're sharing a laugh with a friend or colleague, or when we were talking first, we were all enjoying hearing about a vacation that was recently had by someone, and really being present with them to think about that. So it's really a kind of a shared experience. And that's the beauty of positive emotion, according to the theory. And generally, the research bears it out. It serves a protective function. It's associated with better health and longevity, enhanced coping, meaning making, and builds resilience to stressful events. And there's just a growing number of positive psychological interventions or strength-based interventions, of which many are dyadic and showing efficacy for health and well-being. But in looking at healthcare encounters or healthcare communications, the expression of positive emotion is not a widely studied or comprehensively studied in comparison to empathy or response to distress. So and one thing I just want to point out, that we do think it's that there's an opportunity maybe for clinician enhancement of patient and caregiver expressions of positive affect if used appropriately. And it's important to remember that positive and negative affect are separate constructs, and one doesn't negate the other. So in our second project, the objectives were to explore the types of positive communication used in hospice and identify, again, patterns. We're just after this pattern thing. And so we did a secondary analysis of 70 cases that were randomly selected from the larger data set, and they had to have at least 4 visits. And the participants in the visit length largely relates to what you saw earlier. So again, I'll talk about how we coded this data. We used Seligman's positive psychology pillars to really create deductive coding categories. And what we did was we went back to the RIAS positive emotion codes and then went through those and coded them more with a fine-tuned comb using these categories. So these are the pillars of a positive psychology according to Seligman with one added. So connection. Here's an example of a nurse saying to caregiver, "You'll be in my thoughts and prayers." Savor, take joy, which is my personal favorite positive communication. How beautiful the day is. So sort of sharing that. Gratitude, caregivers to nurses. My glass is so full with thanks. Praise and affirmation used by nurses. You're doing a 300% fantastic job. And a positive focus. And here's an example of a caregiver, I think, really trying to bolster themselves. We can be miserable or we can make the best of it. We've got to get back on our feet and do the best you can with whatever the day is. And then, of course, humor. And the nurse saying, "When I was on the phone, it sounded like a goose honk." And finally, they're what we call perfunctory categories. And we think these are important because there'd be things like, "Okay, good," or "Oh, right," or, and so they can be said, often they're just said sort of, "Okay, good," or whatever, but sometimes they can have a real punch to them, but they're really parts of all of our communication, but probably not as powerful as these others. So our findings is that PAC represents a medium of, if you look at all the talk that happens across all visits, it's about 6%. Positive emotion occurs about 6%. And 61% of all positive emotion communication was from nurses when we looked at all the positive that communication. And what's interesting is that all forms of the Seligman's pillars were used by all participants. And nurses tended to, so what we did is we looked at all nurses we looked at all their positive communication, and what they led with was praise and affirmation at about 23%. And many of these statements are to the caregiver for encouragement or even a compliment, like telling a caregiver that her dress is beautiful. And then these are followed roughly in even measure by human and the perfunctory statements. The caregivers and patients' largest categories was humor, about a third of their talk. And we looked at these closely. We felt they were genuine and often a dark humor where they're finding levity in the dying process. But it's really important, I think, and it deserves further work to understand when humor exists to divert deeper emotions. And finally, the most common category for caregivers and patients is to savor and take joy. And often this would incur, or the next common category, and often that would incur is a memory. And it's especially meaningful when time is limited to share that kind of thing. So you can imagine those are powerful. We did find some slight decreases in humor and savor take joy over time. But again, we really weren't confident that these were clinically meaningful patterns. So just the implications of this for clinical communication, we think positive psychology theory that guides the observational and interventional research is really telling us something about growth and well-being and reduced stress that could be used in clinical encounters. And while interventions typically involve activities like mindfulness and gratitude journaling or something, these are just a few examples, there really are some communications that if we understand the complexity of those, that we when to use them and what would be the best competencies in that it could be a powerful mechanism in clinical communication. I'm just watching my time. So now I'll turn to our third project, which is from our most recent R01. We were funded with a sexual and gender minority administrative supplement. And this work was led by co-investigator Kristen Cloys, who is now at OHSU. And so just a little background, there's really a critical need to study LGBTQ caregivers. They're more likely to be unpaid caregivers than heterosexual cisgender individuals. They report more financial strain. They report more discriminatory work policies and healthcare treatment. And they're less likely to report having conversations with their healthcare provider about the support they need. And believe me, that is a low bar in general. So this is really appalling that they're not having these conversations. So just to talk about the aims of this administrative supplement, we assessed hospice providers' attitudes, knowledge, and training experience. And then we described LGBTQ plus hospice family caregivers' communication and support needs. And so first, just look at hospice provider attitudes. We provided a survey to hospice team members in 3 states and on attitudes towards LGBTQ plus patients and caregivers. And overall, they have positive attitudes. Higher education, a length of time in working in hospice predicted more positive attitudes, and religiosity predicted more negative attitudes. We also conducted focus groups with 48 hospice providers in 3 different states, geographically diverse states, and looked at their knowledge and training and opinions. And here you can see the participant characteristics. Oops, oh shit. Oh, so that's what I wasn't going to do. I wasn't going to cuss when okay. Now I got to get back there. At least that wasn't the worst of the words I can see. Okay, so I'm not sharing. Am I sharing? I'm just sharing my expletives, right? That's all I'm sharing.
Yeah, we don't see your slides yet.
Okay. Okay, now I'm going to try again. I hit the wrong button.
There you are.
Okay, thank you. I think I can move on from this slide. So some findings from these focus groups was that sexual orientation and gender identity, or SOGI data, was not routinely documented or communicated. Most of the hospice care providers reported no specific competency training, but they all desired it. Actually, they particularly desired more training and more gaining more knowledge in working with transgender patients and caregivers. And if patients or caregivers, some of the responses were, if patients or caregivers want providers to know they are LGBTQ plus, they will tell them. So this is about disclosure. And there were some contrasting opinions. And this was related to unique needs at end of life. So some cited death as the great equalizer, the common denominator, and it's a chief reason why these individuals might not have specific needs. That ideas that end of life needs are universal. And so this is represented in this quote: "I don't think it's important. I treat everybody the same. We go to houses or homes. I don't look for preferences. I just treat you like you're a person." And this position was countered in 2 ways, often by the LGBTQ plus hospice care team participants. And first, these participants cited that historical and structural discrimination does affect the experience of patients and families end-of-life needs, and they noted that these structural differences included access to medical information and insurance coverage, and differences in family structure and social support systems. And they also mentioned that older adults may be particularly affected by experiences of mistreatment. And also the participants pointed out the intimate nature, which many of you discussed, of the home hospice care, of the home hospice setting, and how that creates complex and multi-layered vulnerabilities. And that's evidenced by this quote: "It's really allowing a bunch of strangers to come in at a really vulnerable time. So if you add a caregiver that has to worry, are these people going to be accepting? How comfortable do I feel sharing this stuff? That's an extra layer of stress." Okay. And then we also conducted in-depth interviews with caregivers. And here you can see the participants' characteristics. About 50% were caring for a parent. And so from these interviews, the predominant theme that arose was the burden of having to wonder about whether identifying as LGBTQ+ affected the quality of the care that they would receive. And this was an underlying, manifested as an underlying level of uncertainty. So all participants were focused on the potential effect of a difficult communication or a bias from a provider on the dying, what effect would that have on the dying patient, which led to a state of vigilance to intervene on behalf of the patient if it became necessary. So we had one caregiver who didn't want to leave her mother alone because she was afraid there might be some mistreatment due to her mother being gay. And the anticipatory anxiety was common. Participants expressed concern that hospice providers' biases could lead to poor treatment. And then they described decisions about disclosure. And they described these decisions about disclosure to the healthcare team or hospice care team as kind of a risk-benefit calculus. So they were doing this sort of, juggling of whether they should tell or not. And so all of this is occurring at the end of life stage with this historical context, many having challenges with family relationships, and also that they also mentioned there's a lack of resources for LGBTQ+ caregivers, and of course the backdrop of a harsh climate of religion, legal, and cultural issues. So implications for for across this project, implications for competent inclusive hospice care include passing along SOGI data, normalizing that's routine, needs to be routinely assessed, and to partner with. Well, this is one thing I've been thinking a lot about, is really partnering with our community for better hospice training. So we have such wonderful resources for communication, inclusive communication training. I mean, we need more, but we have those in our academic medical centers. And although we try to reach out to the community, it really is imperative for us to impact the quality of care and communication across the spectrum of palliative care. And so it's our duty, I think. And then I just wanted to talk a little bit about questions, and many of you may ask this important question. The first box highlights a question that you might ask a patient: who's most important? Who do you want to be in the room to help with decisions and hold your hand? So asking these kind of open questions may begin to open doors of trust, but it's also important to ask a question of caregivers. So not just the patient, but to the caregiver, I'm not quite sure what this would look like, but who's important in supporting you? Who do you want to help you as you care for? So it's important to think about both of them. Okay. So just, I'm gonna kind of, I guess I'll kind of run through this quickly. So there's some takeaways from all three projects for improved family-centered communication, not just in hospice, but really for all of us to think about. So we need to make changes in education and clinical practice. Obviously, we are all working on upstreaming the engagement of caregivers as members of the team. We need to have earlier discussions and referrals to hospice. We know that. Well, we need more education and curriculum and really support inclusive communication training. And then that's, really focused on our healthcare system and our education system and providers, but there are things we can do with patients and families. So there's some work being done at Mass General on really, doesn't have to be on the back of the providers, maybe a video educational tool about hospice could start those conversations where we can empower patients and caregivers with in preparing for medical appointments and prioritizing their needs. There's work with Jennifer Wolf and others on shared access to the electronic health record by both patients and caregivers. And then all of us need to normalize family caregiving and dying in all our conversations, or well, not all our conversations, but in our communities and in the way we talk. So I'll just use the last maybe 4 or so minutes to talk about the Family Caregiving Collaborative or center, if you will, that we've developed and what led to that. So really, I've talked about this research in hospice family caregivers. We had expanded our last T32 to include family caregiving. And so we really were working with a lot of mentees in this area. And then the National Academies report came out really underscoring that the backbone of older adult care is on the family caregivers. And so all this led me in my professional life to be thinking about caregiving more broadly, but it was also coinciding with my own family caregiving experiences. And I really began to listen instead of clinical encounters, asking families for stories, and like the story from Ron and Mary, whose adult son has a disability and is really not independent, able to live independently. And Ron voiced to me his worry about who would care for his son when he died. And while his family had many resources, he was very, very worried. So these things all came together and led me to think that our university could do more for family caregivers. And some of you may know that Utah is often touted as the family state, and I felt like we should really be leaders in this area. So we developed a mission statement, which is really, and I won't read it now, but the College of Nursing really got behind this and led a campus-wide initiative with researchers, clinicians, health profession educators, and community partners, really to think about really inclusive impact for family caregivers, and began to think across the life course, across disease and disabilities. And so really a much bigger focus now on family caregiving. And I probably won't spend time on this slide, but this is just really reflecting the phases that we've gone through in funding, in diversifying our funding sources in our programmatic activities, and in some of the activities that we do. And we're really in phase 4, where this talking about sustainability and really growing what we're doing, or maybe looking at it in a little different way. But one thing, if some of you that are really thinking about building a center, or rethinking how you want to change your center, expand your center, one thing that we really did at the advice of someone was hire a program manager who was also a organizational strategist. And I can't tell you what a difference this made in the work that we have done. Really how they think about it, how they, we really chose the word collaborative for a reason. We wanted to connect with different entities on campus and the community, and not reinvent the wheel, but really partner to expand the impact for family caregivers. And so really had to think about not having turf wars, but rather about collaborating with a capital C. So we have 4 pillars: science, education, and really policies and advocacy. And then I guess take a moment to say that we've done the least in family-centered models of care and in community-based services. What should we innovate there? And so we're very happy that Lynn Rinke has joined us from you all, and she's agreed to help us with this part. And actually, we're really talking about what direction the center or the collaborative should take next. So thank you. We're happy to have her here at Utah. And so I won't belabor these slides, but we've really doing some work in the education pillar and building models of integrating caregiver competencies into nursing education, but really into all healthcare disciplines, including interprofessional, and really with an eye towards national standards and curriculum. So thinking about not just doing it, but really like making a change at the national level. We've been very active in community partnerships and advocacy pillar. This is works led by Becky Utz. Really, our number one goal is a Utah caregiver state plan. And we have multiple ways we're going about that. And we've really built partnerships with aging and disability communities so that we're all working together to raise multiple family caregivers, not just in aging or not just in disability. And recently our caregiving collaborative, we've worked a lot with NAC, National Alliance for Caregiving. We were one of 7 states that was invited to the first ever caregiver summit on Capitol Hill in DC to advocate for the national strategy. And my work is on the research pillar. So we have lots of colleges and departments involved. We do a lot of activities. And actually one of the things we're doing is investing in good ideas and sort of investing in research startups and paying for FTE and different things in it. So I won't go into details of all the many exciting things we're doing, but just trust me. So if you're would love to collaborate, so please reach out. I'm getting to the end of the talk where I want to really acknowledge the research team members, the Family Caregiving Collaborative team, and our funders. And I'd like to thank you. So I thank you all for this, inviting me in. I'm going to stop sharing. Okay. And I won't start cussing, I promise.
Thank you. Thanks so much for sharing that work. I really appreciated seeing the evolution in the relationship between the projects. It was really helpful in how that relationship relates to the current collaborative as well. So now we can leave space for questions. For Lee, if you have them, you can put them in chat, or you can raise your hand, or if you want to just unmute and go for it, you're welcome to do that as well.
I'm also happy to just talk about, I mean, you have this incredible center. I'm also happy to talk about, you know, challenges or growth or sustainability or anything like that. If you know, always want to learn from others.
Yes, I was thinking the same would be an interesting conversation. Although I have questions about your work.
Okay.
Is really
Okay.
helpful.
So
but I don't want to talk, so I want to give space. No, it's good. I think we should do both. I have a quick question about the piece about, it was really interesting and helpful to hear about how you coded the recordings of the communication and described those. And I was thinking about it, I've been thinking about this lately, but thinking about how, you know, communication is dynamic, and thinking about whether or not y'all were able or started thinking about I'm not sure what you call it, like the temporal aspects or the relational aspects of that communication. Maybe they're like looking at patterns about how particular communication events triggered other communication events, or not. And I was really thinking about that in relation to your project 3, when it had to do with disclosure and LGBTQ
Right.
folks, thinking about how, you know, people really, that sort of vigilance in scanning the environment, thinking about when and if it's safe to disclose. So just curious about if that has been part of the work.
No, I we may have done kind of a lag analysis on something, but I don't remember specifically. But I think that's really important. So what does one member say that triggers the next response? And really with so or even so one caregiver said in Project 3 that many said that they were aware of the uncomfortableness of providers. So it might not even been what's said, but or maybe the stilted nature or the, kind of nervousness or awkwardness of providers. And then that led them to either think, oh, wait, I can't reassure them right now, I'm taxed, or I should reassure them that's all okay, or can I trust reassuring them? So, I mean, that's not really verbal, but that's what's going on in their head. And obviously, if we could capture that, that's just one example. But I think it's really important. And when we, like we did that really big study of looking at every, comment, but we collapsed across all of them and really looked at averages. And that's really just a really gross, I don't mean gross and ugly gross, but big gross way of looking at things. And what you're describing is this sort of response and exchange, I think, is a really powerful way to think of to analyze communication with sophisticated tools.
Other questions?
I did have a question. I thought I was looking at the various funding sources and they're diverse. And I was just wondering how you were able to pull that off. Because we tend to rely on R01s and I'm just curious about how you thought about that, how you orchestrated that. And I appreciate that this is a narrow question, probably interested predominantly to researchers, but I was curious about that. We're always hoping to understand ways we can open up our funding sources.
So I'll be honest, the research was primarily funded by the usual mechanisms, NIH and ACS. And, obviously we did all that secondary data analysis kind of on our, on your own precious time, but it was really, really fun, especially since our aims didn't pan out. But the Caregiving Collaborative is a different beast. And so that has really required different sources. And I'm sure you're all aware of this, but so we're writing foundations. And to be honest, it does really resonate with philanthropy. So, everybody, people, in fact, one of our donors is incredibly well-resourced. I mean, incredibly well-resourced. And her family caregiving experience was awful. And so I think it touches so many people. So that I think it does speak to, and the strategist has been, I have to really credit our strategist who thinks, I don't know how to do all that stuff. I would rather write a grant than talk to a donor, but but they really coach us and all that and think about that. And she was the person that really said, we got to think about a diversified funding source. So NIA will dry up pretty soon. And that really just pays for my time and a little bit other, but I think it's really working with talented individuals in advancement and thinking strategically about foundations. Amy?
Thank you.
Hi there. This is Amy Trowbridge. I'm a pediatric palliative care clinician and have done some much smaller scale communication research. And I was really struck by your findings about positive emotion. And I just wanted to kind of ask a question about that. There was something that, like the statements of the nurses, the praise and the gratitude were so powerful. And I was also, to be honest, a little worried that sometimes the nature of our selves is when a family expresses a really hard emotion, sadness or anger or grief, it can be tempting to want to gloss over that or try to fix that emotion with positive emotion. And so I was curious if you were able to look at kind of the statements before that emotion and like characterize those at all, or if you could just comment on that.
Yeah, I think that's an excellent question. And I think that's what makes this positive emotion a little more tricky than responding to distress. Well, we know you responded, you should respond to stress with empathy, right? But well, maybe that's, but I guess if you respond with some strength building, that may not be the right moment. And I think, I don't know, I just think it's a little more complex. Like you said, the danger of stamping out or suppressing the need to be sad. I actually really like that idea. I mean, Danae brought this up and you're bringing it up too, really looking at the comment before and you know, looking to see, is there a tendency to say, you know, this is hard and say, buck up. We did, I can't say that we saw a lot of that we were aware of, but we didn't do that systematically coding. And I think it's a real danger and really takes clinical skill and thought and art to know when to do it and when not to do it. It's a great question. I don't know about you, but when I'm sad, I hate it when my partner says, well, you know, like that's a sure way into a fight. So
Lee, there's something from Jennifer DeRosa in the chat. Says, please speak to your observations or thoughts about communication techniques and where the sense of urgency may exist, sorry, chat just popped on me. Where the sense of urgency may exist, adding to curriculum for students or post-professional education. You're on mute.
sorry, I don't know how that happened. I'm not, so where the sense of urgency may exist, I'm not, oh, if I don't know, Jennifer, if you can speak, but I think I mean, I guess if we're going to assess patients and we're going to send them home or we're going to ask someone else to care for them, then it should exist wherever that happens, right? I'm not sure that's what you're asking. So we really think about identifying who's going to provide the care, assessing if they're able and willing and can provide the care, and then do they need any support? I'm not sure I'm answering your question though, but it is urgent.
This is Jennifer. Thank you so much for that. I was just sort of wondering in terms of your education around communication technique training for professionals, are you looking more, are you seeing more of a need during the curriculum when students are, you know, obtaining these degrees, or nursing students, or are you thinking more about this ongoing post-professional education now that people have these experiences under their belt and we're really identifying opportunities because of that lived experience to really sharpen their communication skills?
Oh yeah, you've articulated that very well. Yeah, and I think it's across the board. It needs to be foundational in education. We actually did a review of national nursing documents, and family caregivers were only mentioned as difficult family members. There really wasn't any teaching or standardized curriculum standards for assessing caregivers. So I think it's across the board. For all of us at all stages.
Thank you.
Okay, thank you. Very good. Just join me in thanking Lee for sharing her time with us. You'll notice Shanitra has also put a link to do an evaluation of the presentation in the chat that's available for you. All right, thank you so much for joining us. It's nice to meet you.
Thank you. Thanks for having me. Bye, everyone, and have a good week.
Yeah.
Okay,
Take care.
bye.